have ample time for discussion and we are not rushed. Alors, pour ceux qui paniquent à l'idée de l'anglais, un mot de précision avant de présenter la professeure et l'intervenante. La séance est enregistrée, vous voyez la caméra ici en plein milieu, et l'enregistrement vidéo sera normalement disponible en début de semaine prochaine. Donc ne vous inquiétez pas, il sera même peut-être posté sur YouTube, donc vous aurez la fonction sous-titres pour éventuellement vous aider. Et dernier point sur l'usage des langues, si vous avez envie de poser des questions mais que vous n'êtes pas à l'aise pour prendre la parole en anglais, vous pouvez les poser en français parce que, comme je vais le présenter dans un instant, l'intervenante est française et donc elle comprend tout à fait le français. This being said, I'll switch back to English. Just first to thank you for being here today for this guest lecture. It's organized in the framework of a specific research project, Jean Monnet Center of Excellence that the Institute for European Studies, which I have the pleasure to direct, has been conducting now for almost 3 years, and we are approaching the end of it. It's a project that centers around the question of the European Union and the question of inequalities, how the European Union may be helpful to address inequalities in European societies, or how the EU might eventually aggravate some inequalities as a consequence of an unexpected result of EU law. And within that project, we have a series of guest lectures, some centering around the questions related to environmental justice, but others concerning more the question of health. And this is linked to like a concern or questioning that we had after the COVID-19, when there was a lot of discussion about how the pandemic had an unequal effect on European populations, how some people didn't feel so much the consequences of the pandemic, whereas for others, they encountered very severe economic, human, but also health consequences. And so for this reason, we planned a series of lectures on this question of the EU and health. Last year, we had the pleasure to welcome Eleanor Brooks, a professor from the University of Edinburgh. And this year, we have the pleasure to welcome the professor Eloïse Gennet from the University of Aix-Marseille, who is a junior professor, holder of a chair specialized on European health law and European law on medicines, so a key expert to address these questions. And so the idea is to give the floor to Professor Gennet for approximately 45 minutes, and then open the floor for questions. And as I said, you are free to ask those questions in English or in French, and also to avoid any shyness or reserve. The questions will not be posted on YouTube. So the recording will only be the 45 minutes lecture, and the Q&A and the discussion with the room will be left out of the published recording. So things being said, I'll give the floor to Eloïse Gennet, that I warmly thank for being here today, and I wish you an interesting discussion.
Thank you very much. Thank you very much for this very nice introduction. And I would also like to formally thank you, Professor Brière, for this invitation, and to thank the Center of Excellence, EUqualis, for giving me this opportunity to talk to you about EU's expanding role in fight against pandemics. I'm very glad to be here. I'm very glad to be in Brussels. As Claude Brière said, so in the aftermath of COVID-19, the EU legislator has taken some major reforms to remedy some of the weaknesses and inequalities that have been observed during the pandemic. And one of the solutions that the European Commission is suggesting is to adopt a One Health approach. That means tackling animal and environmental root causes of pandemics. So by way of introduction, and before we actually come to the main points I will try to make today, I'll quickly clarify three main aspects of the topic so that we all start with the same set of information. And to begin with, I would like you to understand how the EU has managed to gain more and more competence in the field of public health with time, despite their historic reluctance of member states to concede the slightest power in the field. Because initially, treaties made no reference at all to health. Health was ignored in the treaties, although it was unavoidable in the integration process. So health was everywhere on the internal market. Freedom of movement applies to in areas that affect pharmaceutical products, medical services, healthcare workers, patients, and when it's not the case law of the court that applies the internal market rules to areas in the field of health, it's the EU legislator that indirectly coordinates the protection of health. So the very first directive, for instance, on medicinal products was adopted in 1965 on the basis of the internal market. The very first directive on the protection of health and safety of workers dates back from 1989, and the social protection of workers was also extended to EU citizens with a regulation of 2004 on the coordination of social security systems. EU environmental law also has the objective of protecting human health, and so does the common agricultural policy. If we think about in the 80s with the ban of the use of hormones in animals that were designed to be consumed by humans. So all of these different fields do participate in protecting health, but they're not based on any legal basis directly dedicated to public health. They're all founded on other legal bases of the treaties. So with time and the successive treaties, the member states have gradually delegated a bit of power to the EU, but only reluctantly, and usually after a health scandal. The infected blood scandal, for instance, in 1980s, and you probably heard about it, where a lot of batches of infected blood circulated throughout Europe and contaminated patients after blood transfusion. They're contaminated with HIV or hepatitis C. And after that scandal, that's where we see the addition of an EU competence for the quality and safety of organs, blood, or in general, substances of human origin. Similarly, the addition of a competence of the EU on health measures in the veterinary field and plant health field was linked to the mad cow crisis that you probably also heard about in the 90s, where UK cattle were suffering from a fatal disease that was transmissible to humans as well, with the maladie de Creutzfeldt-Jakob. So historically, health scandals have often forced EU member states to admit the added value of the EU in the field of public health, and it's put pressure upon them to delegate a bit of power every time. So it did not so much reflect a proactive desire from them to cooperate in the field of health, but it was really just a reaction to health scandals and a reaction to this gradual and uncontrollable involvement of the EU in the field of health through the use of these non-specific legal bases with time. So giving a competence to the EU in the field of health was rather a way for member states to take back control, to agree to delegate a bit of competence, but to frame it strictly and have more control about it by framing it in expressly and debated agreed upon conditions. So throughout the different treaties, the EU has gained a bit more competence. So how does it look like now? So by exception, with the paragraph 4 of this article, there is a shared competence in the quality and safety of organs, blood, substances of human origin. But that's really by exception. Of course, measures in the veterinary field and medical products, medical devices. That's the exception, basically. After that, we also have the principle of integration. Public health should be taken into account in all other fields that the EU is acting in. The EU also has a supporting competence to coordinate and improve complementarity of health services in cross-border area, so only a supporting competence. Paragraph 3, it's about fostering fostering cooperation with third countries and international organizations, and we will have an example about it during this session. Paragraph 6, so the Council can adopt recommendation, will also cover one particularly important one for the One Health approach today. Paragraph 7 is quite interesting because it's a reminder of state sovereignty. So it bears witness of this reluctance that I was talking to you about. It's a safeguard that they've put in the treaties to make sure this competence in the field of public health stops growing. So that's a disclaimer that is written down very clearly in the treaty. And last but not least, the Union has a supporting competence to adopt incentives measures designed to protect and improve human health. That concerns cross-border health threats, tobacco, alcohol, and these incentives measures may under no circumstances be harmonization measures. Though that means that the EU really only has this role to support, coordinate, under no circumstances harmonize national legislations. And that's the legal basis that we are going to be interested in today, because it's the legal basis for cross-border health threats, for the fight against pandemics. Which leads me to the last point of my introduction. So before COVID-19, the EU legal framework was quite weak in the fight against cross-border health threats. We had this decision, this 2013 decision, which was adopted in the aftermath of the H1N1 pandemic. It was the key legal instrument to coordinate measures, like response measures in the case of pandemics. But when COVID hit, it became obvious that this decision was insufficient, mainly because it primarily encouraged voluntary cooperation among member states, meaning there were no legally binding EU-wide measures for pandemic preparedness or response. So it was not enough to avoid the fragmentation, that we could observe during the COVID-19 pandemic in the different responses of member states during the pandemic. So this was one of the main shortcomings. There would be others, but this mainly explains why the whole system needed to be reformed with a new regulation, a 2022 regulation on serious cross-border health threats, so in the aftermath of COVID-19. Among other things, this regulation establishes binding requirements for the EU to have its own pandemic preparedness plan. So member states had already this obligation under international law with the international health regulations from WHO, but not the EU itself. So what the EU did with this regulation is oblige itself to have a similar obligation than in international law to have a pandemic preparedness plan. So that's one main thing. It also established a requirement for member states to cooperate with the European Commission and different EU agencies to have these preparedness plans monitored. Because even if it's an obligation that they have under international law, there is no monitoring by the WHO itself. So they have this obligation, but there's not enough funding to have really constructive feedback that would be formal. There's no monitoring body. So what the EU does with this regulation, so it obliges itself to have a pandemic preparedness plans, and it obliges member states to submit to this monitoring system, at least at EU level, so to have more efficiency. So there would be many more provisions we could mention, but let's stick to the most important ones. Other pandemic, like post-pandemic instruments have also, beyond this whole regulation, have also empowered EU agencies, like for instance, all those that were at the front line basically during COVID-19. So we think of the European Centre for Disease Prevention and Control, or the European Medicines Agency, for instance. So both have had their mandates straightened to give them more power in case of a future outbreak, to improve preparedness. And last but not least, one of the key measures taken after COVID-19 in September 2021 was the establishment of a brand new authority, the Health Emergency Response and Preparedness Authority. And this authority is focusing on basically securing medical countermeasures that were missing during the pandemic. So this authority will take on that role in securing vaccines, treatments, stockpiling, and coordinating the joint procurement between member states and pharmaceutical industries when buying together vaccines or treatments, for instance. So that's the role of this brand new agency. So those are the main reforms that have been undertaken, but today we will talk about this focus on the very new aspect that this regulation, this 2022 regulation, is also enshrining, so to say. And I will start by explaining what is this One Health approach and why we need to apply it, or why the European Commission wants us to apply it to prevent the next pandemic. So I will present you the One Health approach in these three main aspects. First of all, it's a cross-sectoral approach, it's a preventive approach, and it's a global approach. And we'll go into detail to explain that. So the most obvious part of the definition, have you ever heard about the One Health approach in the past? Nobody? Or even just seen it, or in one of the, maybe discourse, of the European Commission? So basically, the most obvious part of this One Health approach is the idea to recognize the interdependence between human health, animal health, and ecosystem health. And I will explain that very concretely with two examples, that, of course, of COVID-19, or in general, zoonosis, and with antimicrobial resistance. Two examples. COVID-19 is indeed the perfect illustration of the interdependence of human health, animal health, and the environment. We know that global warming, environmental pollution, or declining biodiversity encourage the emergence and circulation of pathogens in animals. It's not so much that it creates new viruses, it's that it allows viruses to develop where it should normally be diluted in a high biodiversity. So in ecosystems with high biodiversity, the virus will be transmitted to many different species, and a lot of which will not get sick, or at least not be able to transmit the virus further. So they will act as diluters because of their weak competence in transmitting the virus, they will make it gradually disappear. So this is the dilution effect in a high biodiversity setting. However, in ecosystems with low biodiversity, this dilution effect is disrupted because there are fewer host species. So the fact that a same animal will get infected, or same species will be infected over and over again, will increase the concentration of the virus to the point that this animal will infect other, or it will be able to infect other species, including humans. So that's one important thing about the declining biodiversity and its link between virus circulation. But beyond declining biodiversity, we also know that urbanization, deforestation, and all the consequent loss of natural habitat of animals leads them to being in more frequent or closer contact to humans. Another thing we know is that the increasing exploitation of animals for agriculture, for farming, to meet the growing demand in meat and dairy products, also leads sick animals to be in close contact to humans more than they should. And this continued promiscuity over time enables pathogens to adapt to humans and to infect them and create zoonosis. And zoonosis is an infection that is transmitted from an animal to a human. And about 70%, that's huge, 70% of viral infections in future pandemics are zoonoses. They are transmitted from animals to humans. That was the case for Ebola, SARS, avian flu, HIV, you name it, monkeypox. But alongside these viral infections, there are also concerns about bacterial infections, particularly bacterial infections that are resistant to antibiotics, which leads me to my second example. Antimicrobial resistance simply designates our resistance to antibiotics. It's when a bacteria has a resistance gene that stops the efficacy of the antibiotics. So we talk about a silent pandemic. Even the European Commission talks about a silent pandemic of antimicrobial resistance because it is indirect. So the link between antimicrobial resistance and death is only indirect. It's the disease, that's the pneumonia, for instance, that kills, and that's what we remember. But antimicrobial resistance doesn't kill you directly, it just deprives you from the cure that could save your life. And the resistance spreads like a pandemic. In two ways, actually. So it spreads with the normal duplication of genes. That's what bacteria do. They replicate. And so a resistant bacteria will pass on the resistance gene to all their duplicates. Every time we use an antibiotic, we basically kill all bacteria except the resistant ones. So that's all what is remaining. And then all the bacteria come back to colonize and reproduce. But the resistant bacteria will always be one step ahead. So every time, with each use of antibiotic, the general proportion of resistant bacteria increases. And this becomes problematic when the bacteria is pathogenic. So If it spreads to a non-resistant bacteria, then that's fine. It duplicates, but then you apply an antibiotic, the pathogen leaves. That's fine. If the resistance, like you can see in red here, if the resistance is spreading to a resistant bacteria, then it will normally duplicate and multiply, and you may apply an antibiotic. It won't stop the progression of the disease. And on top of that, there is a second way that the resistance is spreading. It's the horizontal gene transfer this time. So resistance genes can just simply infect. They can infect the neighboring bacteria just by simple contact, and it can infect normal bacteria or pathogenic bacteria. So for almost a century, we didn't have to worry about that because we had discovered antibiotics. It was working fine. But now that resistance is spreading, it kills about 700,000 people each year. And this, like worldwide. This is the numbers that the EU is using. So this is what I'm telling you right now. But you have to know that other scientists, or WHO, for instance, give a lot more scary numbers. So this is just the EU numbers. But this could rise up to 10 million deaths per year by 2050. But whatever the number, this would be in any way a return to the times where a simple microbe could kill, or when, for instance, surgery could become much more riskier. And as I was saying, antimicrobial resistance is the ultimate One Health issue because its development factors go way beyond human health only. This is probably what we hear the most about. It's the overuse of antibiotics in humans. You had heard about it, no? Les antibiotiques, c'est pas automatique. Things that we heard all during our childhood. But this is not the only problem. Of course, the overuse, as I showed in the last slide, of course, the overuse in human will help the resistance spread. And it sometimes reflects the quality of health system. Understaffed health system will tend to use more antibiotics because there's not enough time or money to wait and monitor a patient. Bad hygiene also leads to the spread of bacteria and thus an increased need for antibiotics. But the overuse of antibiotics in humans is far from being the only or even the main factor of antimicrobial resistance spread, because antimicrobials are mainly used in animals. And we basically use the same antibiotics, and we share the same resistance genes. So the spread of the resistance in animals will impact our health. So this concerns, of course, our pet animals, but it also mainly concerns farmed animals. For instance, in the US, about 70% of the sold antibiotics are for animal use. So the growing demand in meat and dairy products leads to an ever-increasing supply and production of low-quality, low-priced meat. And sometimes antibiotics are even used for animal growth. This is banned in the EU, but this is not the case everywhere in the world. And even when antibiotics are not used for growth, they can still be overused because of poor hygiene conditions, because of overcrowded premises. It's the case of most intensive farming structures, and because it's cheaper to overuse antibiotics than invest in vaccines. And humans will also have more chances to get contaminated in such conditions. By simple contact with animals, with their excrements or with the raw meat. That's breeders, veterinarians, persons involved in slaughtering, and there may even be contamination at the end of the production chain of the consumer when the meat is raw or badly cooked. So antimicrobial resistance is as much about animal health than it is about human health. And those sectors are usually regulated separately. But there is another major category of factors in the spread of antimicrobial resistance, which are environmental factors. So first and foremost, like for viral pandemics, it's all the factors that promote contact between humans and animals. That means deforestation, urbanization, wildlife trafficking, animals lose their habitat, come closer to areas frequented by humans. Another major environmental factor is waste management. Organic waste, human excrements contain active bacteria that can be resistant. Animal excrement contain active bacteria that can be resistant. And some of this waste can contaminate water, can contaminate soils, particularly in agricultural fields, when sometimes animal excrements are even used as fertilizers. And this can contaminate consumers in the end as well. And the problem is that chemicals or pharmaceuticals, pollutants, are almost impossible to filter. The way we throw away antibiotics at home. It's the way the management of the waste from the pharmacy or from the hospital. So even state-of-the-art technology won't be able to eliminate totally actively resistant bacteria from anything. It's also the pharmaceutical wastes for the production of antibiotics, for instance. And it contaminates wastewater, it contaminates the fish, and it contaminates the person who is consuming raw fish, for instance, and it contaminates agricultural fields again if the wastewater is used in the production. So, and add to that, global warming, that is scientifically, it's been scientifically proven that it accelerates the speed of the spread of the resistance. It hasn't been clearly demonstrated for viral pandemics. For instance, for COVID-19, you have contradicting studies about it. But for antimicrobial resistance, it's very scientifically proven that the hotter it gets, the faster it spreads. So this is why it goes way beyond our own responsibility to try and use antibiotics less systematically. There are structural factors that can also be regulated, acted upon. So with both these examples, COVID-19 and antimicrobial resistance, we understand the reasoning behind the One Health approach and its focus on breaking silos between disciplines that are usually regulated separately. Because we need to take into account this interdependence between animals, humans, and the environment. So One Health is cross-sectoral. But One Health is also about prevention. It's also about deep prevention. It focuses on addressing root causes of pandemics like biodiversity decline, waste management, global warming. The aim of the One Health approach is to prevent an infection from emerging in the first place. So rather than only preparing for an outbreak, of course it's important to prevent an outbreak, to prepare to have enough masks, to have enough medical countermeasures. We need to make sure of that, but it usually works better. It's more efficient to prevent this from happening than to prepare for the outbreak. If you think of COVID-19, for instance, we managed to have vaccines quite rapidly in comparison to a normal process of research and development for vaccines. It was quite efficient, but it was, even if it was exceptionally quick, it wasn't quick enough to avoid the millions of deaths worldwide. And it has been already established that other potentially more serious threats will arise in the decades to come. That's what Dr. Tedros Ghebreyesus, who is the Director General of the World Health Organization, that's what he calls disease X. So a future virus could definitely be quicker to spread than COVID-19. And most of all, a future virus could also be a lot deadlier. In those cases, the time pressure to develop a vaccine or a cure would be even higher. So this definitely speaks in favor of adopting a deep prevention approach rather than to prepare for a pandemic. And in case you were still not convinced, let me cover the case of antimicrobial resistance again. So one aggravating factor of antimicrobial resistance is the lack of research and development into new antibiotics. All the pharmaceutical industries are gradually abandoning the field. They're stopping research in the field of antibiotics. Novartis halted all its research in 2018. AstraZeneca, Sanofi stopped already in 2016 because it's not attractive enough anymore. It's not financially attractive enough anymore. Do you have an idea why? Because we could say, well, there is a need. Our antibiotics are not working anymore, so there's money to do here. So if there is a void, if there is a need on the market, it should be easy to sell antibiotics. So it's probably worthwhile investing in research and development to develop a new antibiotics. But apparently it's not attractive. Do you have an idea why? Yes. Yes, that's one thing. That's one important aspect of it. If the antibiotic is not new enough, if it's just a part of a I don't know in English, une souche, if it's something that is already existing and that has only a slight benefit in comparison to what is already existing, the price will be low because it will be priced like a generic medicine. So that's one important aspect indeed. But there are other things that would explain why it's not financially attractive. Okay, first there are three other elements here. One is that you have to bear in mind that the last antibiotic that was discovered was in the late 80s. So all the easy ones have been discovered. All the easy antibiotics are already discovered. Then, number two is even if we try to slow down the spread of the resistance, it keeps spreading, and the speed at which it is spreading keeps accelerating. So I'm just guessing here. Well, it might have taken 50 years for an antibiotic to become ineffective because of resistance. Nowadays, it may only take 20 or 30 years. And it's really, I'm inventing numbers here, but it's just to give you an idea. So if the industry needs several decades of sales before getting that return on investment, then maybe the sales will be dropping already before it gets the return on investment. So it won't generate enough profit or not soon enough. And the third element is that a lot of public health policies encouraged by WHO or the European Union, for instance, will encourage sobriety policies to try and slow down the spread of the resistance. So that means that if a pharmaceutical industry develops a new antibiotic, they know already that all the public institutions will try to make they keep that antibiotic and not sell it, or sell it as the least possible, to only keep it for worst case scenarios. We will keep it warmly safe in a box and not use it until we really, really need it, until a patient has tried all the antibiotics that are still available in the world and it has not worked. And then as a last resort, we'll use the new antibiotics. So that's not good for sales either. And that's why we really need to improve prevention strategies, because therapeutic strategies are clearly abandoned in the case of antimicrobial resistance, or they might be too slow in the case of a viral pandemic. There might still be too slow to prevent the many deaths that are inevitable in the future major health threats. Last but not least, the One Health approach is also a global approach, because COVID-19 was also a reminder, a perfect illustration of our interdependence at global level. It's the fact that the isolated spillover incident somewhere on a market in China becomes a pandemic within a few weeks. So the One Health approach is not only about breaking silos between disciplines and sectors, it's also about accepting that public health cannot be protected and promoted in isolation from the rest of the world. And it's not only about people being able to travel around the world, it's the fact that the root cause of a pandemic or of the emergence of pathogens lies in worldwide activities raising the Earth's temperature. It's about global warming that makes it possible for tropical infections to slowly spread in regions where it would normally have been too cold in the past. Or it makes it possible for transmitting animals, for instance, mosquitoes, to also expand their territory and survive in regions of the world that were too cold before, and they can now spread infections in those regions as well. And one last point is also global warming. That is a ticking time bomb in that regard. You've probably heard about permafrost. So permafrost is basically, it refers to soils that are frozen below zero degree for at least 2 consecutive years, a lot more usually. And permafrost freezes virus and bacteria, but it releases them back when it melts. And the media was quick to choose the catchy name of zombie virus. So in 2016, for instance, after repeated fires in Siberia, an anthrax bacteria released by the melting permafrost killed hundreds of reindeers and even a young boy. And in general, there are many scientist studies that show the re-emergence of viruses that are thousands of years old. And some of them are harmless to humans, but what if the next zombie virus was aggressive? I'm sorry for this quite negative note, but it's just to emphasize why the One Health approach also refers to the whole planet, because our health is interdependent at global level. And we come back to the initial idea of One World, One Health. This is this high-level conference that is said to have propelled the concept of One Health onto the international legal scene with international NGOs, but mostly with a lot of UN agencies during that conference. So we've established the link between global action and EU action, why EU action may impact global health and vice versa, how international or global action might impact EU health. So, but how do we translate that into law, and notably into EU law? Since COVID-19, the One Health approach has made its way into institutions and agencies of the European Union. So firstly, the European Commission, its Directorate General for Health, has set up in October 2022 a directorate that is specifically dedicated to One Health. This institutionalization can also be seen in the emergence of the One Health approach in the mandates of different EU agencies, the ECDC, the European Food Safety Authority, and both of these agencies have created in June 2023 an interagency task force to straighten the scientific advice of EU agencies on One Health. So along with the European Chemicals Agency, the European Environment Agency, and the European Medicines Agency. So it made its way into institutions. Another interesting thing is that the approach also started to appear in strategic or policy documents at EU level. This appeared for the first time before COVID, actually, in 2017 with an action plan on antimicrobial resistance with the One Health approach. And after that, there are several, I haven't put them all in it, but a strategic approach to pharmaceuticals in the environment, a EU soil strategy, or more interestingly, the 2023 recommendation of the Council on antimicrobial resistance. And if you remember, that's Article 168, paragraph 6 in the EU competence in the field of health. But most of all, the One Health approach has also been defined in EU law. It has been defined as a multi-sectoral approach which recognizes that human health is connected to animal health and to the environment, that actions to tackle threats to health must take into account those three dimensions. So this definition became part of post-pandemic law with the EU for Health regulation. So after COVID, the regulation establishing a program of EU action in the field of health. And it was taken up again in the regulation, in the 2022 regulation on cross-border health threats that I was talking to you about the fight against pandemics. But even if it made its way in binding instruments, we don't really know for sure whether this One Health approach can become a prescriptive concept. It's because it's a fact, it's a scientific observation that's just about observing this interdependence between animal health, human health, and the environment. And from observing this scientific fact, we can, of course, elaborate policy methods, a to-do list on how to better prevent pandemics. But it is not clear whether it could actually create normative obligations aimed at minimizing health risks at the human, animal, and environment interface. So in that regard, the fight against pandemics will be sort of a pilot project to implement a One Health approach and to see whether this can become a prescriptive concept or not. And indeed, the European Union promotes this One Health approach as much as possible, at least at EU level, in its framework on the fight against pandemics, but it also promotes this approach at international level. So first at EU level. Instruments on antimicrobial resistance and cross-border health threats promote the approach and set the base for it to be operational. So they have concrete provisions that allow to implement it. For instance, it's sometimes hard to isolate because it's a very transversal approach, but I'll just give you a few examples. It's, for instance, about the European Commission providing One Health training and education to healthcare staff, for instance. It's about funding of One Health-related initiatives and research through EU program and action in the field of health. It's about this new obligation. I was talking to you earlier that I was telling you that the EU is obliging itself to prepare a pandemic preparedness plan, and it obliged itself to do so with a One Health approach. So the European Union cannot oblige member states to adopt a One Health approach, but it can lead by example by obliging itself to prepare for the next pandemic with a One Health approach. So it's leading by example. Another thing is this interagency collaboration that I was talking about earlier, because multi-sectoral risk assessment is crucial. So how do we cross the data sooner between animal health or animal health, human health? How do we cross that data in epidemiology sooner? Maybe we could have not prevented, but at least anticipated COVID-19 a little bit better. So really this multi-sectoral risk assessment is quite crucial for that. However, then again, those One Health provisions are rarely binding for member states. The EU for Health regulation is only a funding tool for research. The AMR, the antimicrobial resistance recommendation is by definition non-binding, and the regulation is binding, but it is based on Article 168, paragraph 5 of the treaty, meaning that the European Union also only has a supporting competence. So it can only coordinate the response of member states, but it cannot harmonize legislations. It cannot harmonize national laws. So it can only oblige them to cooperate, for instance, in this monitoring of their pandemic preparedness plans, but it cannot harmonize the content of these preparedness plans. So now that we've seen what the EU is doing for One Health, or rather that we've seen that the EU's scope for action is relatively limited, you can start to understand why or how important it is to act also at international level. And besides, a small detour in international law is anyway necessary because several United Nations agencies have actually preceded the European Union in that field. So in 2010, we have a tripartite alliance that was created between the World Health Organization, the World Organization for Animal Health, and the Food and Agriculture Organization. And in 2021, so after COVID, this tripartite alliance became a quadripartite alliance with the addition of the UN Environment Programme. And this quadripartite alliance works at the intersection between human health, animal health, and the environment, notably through the activities of a newly created expert panel, the One Health high-level expert panel. And you've probably heard about current negotiations of a pandemic agreement. Have you? Like, not if you have? No? Okay. So since December 2021, WHO has launched an international negotiating body to draft and negotiate a future pandemic treaty, so at international level. And it would be the perfect occasion to enshrine this One Health approach globally, because it offers a framework for addressing all the interconnected factors that drive pandemics. So we had, of course, these international health regulations at WHO level, but these regulations have a limited scope. And the goal of this pandemic agreement, pandemic treaty, if they negotiate it until the end, is to address what is out of scope of the international health regulations, and that includes One Health issues. And interestingly enough, the European Union seems to be determined to promote this One Health approach in the fight against viral and bacterial pandemics at EU level, despite this weak competence, but also at international level. And I explained to you how she's trying to do so. So almost exactly 2 years ago, in November 2022, the European Commission published its new global health strategy. So if you remember, Article 168 of the treaty, in its paragraph 3, it allows the EU to foster cooperation with third countries and with international organizations. And what is particularly striking in this global health strategy is that more than anything else, it gives an important place to environmental root causes of ill health in general, but of pandemics more specifically. And it clearly revolves around this One Health approach in preventing global health threats. And more precisely, it is literally, you can see in the slide, it is one of the 3 core priorities of the strategy: to fight global health threats and to do it with a One Health approach. And in fact, the global health strategy underlines the need to intensify the work with this quadripartite at UN level. It underlines the need to adopt concrete provisions on antimicrobial resistance with the One Health approach. It underlines the need to promote deep prevention. It's about identifying root causes of the threats before a pathogen crossed from animals to humans, then only preparing for the outbreak. And most of all, it underlines the need to negotiate an effective, legally binding treaty with a One Health approach at WHO level. So it's directly referring to these negotiations at WHO level. And so does the European Commission. Indeed, the Commission uses its political weight to encourage member states to commit internationally to adopting a One Health approach. So it's been actively involved in the negotiations at WHO, and its representatives have repeatedly and explicitly argued on behalf of several EU member states in favor of adopting a One Health approach with different amendments, but for instance, by suggesting to formulate One Health as a principle rather than only giving it a definition. So having it become an actual prescriptive principle instead of just a simple approach that is defined in the pandemic treaty. It has also suggested, for instance, to create a panel of experts subsidiary to the Conference of the Parties that would be tasked with giving scientific advice to the parties, like it would be a One Health, the equivalent of the IPCC, like a One Health GIEC, for instance. So the European Commission clearly wants to empower WHO at international level, and it uses its political influence at international level to compensate for its weak competence in the field of health at EU level, and to promote then the political agenda that the European Commission thinks is a priority, and to then implement it at EU level. For instance, through the monitoring of these preparedness plans that are an international obligation that the EU would monitor at EU level because the WHO doesn't do it. And the European Commission clearly admits it in the Global Health Strategy in Principle 16. It recalls that the substantial financial contribution to WHO by the EU and its member states should be reflected in proportional decision-making powers, and that those decision-making powers should reflect also EU's priorities at international level. And in this case, it doesn't only concern the One Health approach, but it's definitely part of it. However, the American presidential elections may jeopardize the rest of the negotiations at WHO, if not the future of WHO in general, if Donald Trump would decide to, as he did in 2020 already, to withdraw from WHO again, and along with its massive financial contributions, because WHO is quite poor. And this is exactly what states wanted to avoid in the first place. So with this pandemic treaty, they launched the negotiations in 2021, and they wanted to finish and sign a pandemic treaty by May 2024. So they failed to reach an agreement by May 2024, and they postponed to May 2025. So risks are now for the entire negotiations to fail, or what is more probable is for these negotiations to only reach watered down obligations and low funding probably as well. So that would be a significant opportunity wasted, but let's hope for the best. Now, as a conclusion, the things I would like you to remember, first of all, is how the EU gradually built up its competence in health law with time, despite this continuous reluctance of member states, and thus always as a compromise. Because health is so transversal and it's impossible to avoid it when constructing EU's integration. And because many health crises have shown the interdependency of member states and the added value of EU action. But keeping in mind that the EU only has a supporting competence to coordinate the protection against cross-border health threats. It cannot harmonize legislations, and COVID-19 was apparently not a big enough crisis to revise the treaties and give more competence to the EU, at least in the field of cross-border health threats. Then it has been established that major health threats will appear in the near future. It's not a matter of whether or not it will happen, it's just a matter of when it will happen, at what speed, and at which death rate. It's as crucial to adopt this One Health approach to fight against those future health threats, be them viral or bacterial, and that means breaking silos between human health, animal health, and the environment. That means implementing deep prevention, preventing the threat from emerging rather than only preparing for the outbreak. And that means straightening the international framework in the fight against pandemic because of our global interdependence. So it is not clear whether it can or will become a prescriptive concept, this One Health approach. But what is clear is the EU's intention to make this approach binding at international level and operational at EU level. So even if the European Union's competence in the field of public health is not reinforced, it is clear that the EU remains ambitious, and it continues to extend and use all possible and available means to act in the field, including by using its political influence on the international stage. And that was it for me, and I thank you for your attention.